Up next, I have the pleasure of introducing Dr. Jason Howard. Dr. Jason Howard, specializing in orthopedics and serving as our MDA Care Center Director at Nemours Alfred I. duPont Children's Hospital, will be focusing his presentation on orthopedic aspects of spinal muscular atrophy, challenges and opportunities in the gene therapy era. With that, I will hand it over to you, Dr. Howard. Thank you for being here today.
Thank you very much for inviting me.
Of course.
Just bring up my screen here.
Perfect.
Okay, so like Mallory said, I'm going to talk about orthopedic aspects of spinal muscular atrophy. And I think this is a really exciting time for us in the orthopedic world and otherwise, given the gene therapy era that we're in right now and the new opportunities we have for treating this neuromuscular disorder. I have some disclosures, some grants, and I really want to acknowledge the Nemours Muscle Clinic members, my partners, Dr. Scavina, Rob Heinley, and Eileen Shea especially. Spinal muscular atrophy, as we all know, is relatively common in the neuromuscular world. Autosomal recessive inherited disorder and progressive along a spectrum related to the age of onset of symptoms. And the anterior horn cells are affected, leading to a lower motor neuron type syndrome. We have very low muscle tone, weakness around the hip girdle area and trunk with involvement of the respiratory muscles as well. And the sort of traditional classification that we still use in orthopedics, although recognizing that this is a spectrum of disease, from type 1, 2, 3, and also 4 in the adult onset. There are some other nuances to that I won't get into today. But basically, the type 1s are more severe, with severe motor delay and respiratory issues, which have really been affected a lot by the newer disease-modifying agents that are in use today. Type 2 are the kids who can sit, but mostly need a wheelchair for mobility. Their functional course is also being impacted positively by gene type therapies. The traditionally ambulatory type is the type 3, where you have later onset of symptoms. And orthopedic treatment in this group is really not controversial. We typically do whatever we can to keep them ambulatory and to keep their function going. And it all comes down to the survival motor neuron protein, which is, of course, coded by the SMN1 gene. And the protein is affected by that gene's involvement with a concomitant anterior horn cell degeneration in the spinal cord itself. The SMN2 gene is a helper type sideline gene, if you don't want to call it that way, that can make the spinal motor neuron, survival motor neuron protein. And it's related to the number of copies that you have as how good it is at doing that. But typically only about 5 to 10% of the SMN protein is made. Disease-modifying agents are targeting these two genes and have really helped us in the orthopedic world to be able to offer more things for patients that we didn't tend to offer in the past. Just briefly looking at these agents, most common one, nusinersen, which modifies the splicing of SMN2, giving us more SMN protein to work with, and that's been shown to improve function and survival in SMA. The gene replacement of the SMN1 gene, Zolgensma, its trade name, has also given similar improvements in function. And these have really changed the way that orthopedists are thinking about SMA as kids and young adults get better function and can tolerate surgical procedures a little better. At Nemours DuPont, Dr. Miller developed this port for the intrathecal administration of nusinersen, and this has really helped a lot of our patients to avoid the repetitive lumbar punctures that are required. I just thought I'd put it up there, and he's published his results on that. Orthopedic aspects of spinal muscular atrophy are very similar to what we find in other neuromuscular disorders. Scoliosis being quite important for seating imbalance and also standing and walking impairment where that's possible, and has some impact on respiratory dysfunction, though probably not as much as we thought it did. Hip instability, as well, the hips coming out of the joint over time, is a problem in SMA, probably more prevalent in this disorder than other neuromuscular disorders, and can lead to painful arthritis as untreated in some kids and adults. Fractures are common, low bone quality and health with the fractures of the tibia femur happening, and this seems to be related to the type of SMA. Gait abnormalities traditionally seen in type 3, and now with disease-modifying agents, we're seeing them in type 2, as I'll show you a little later with a case associated with lower extremity muscle contractures, which we'll get into, hip instability. And for those kids who don't walk but can stand for transfers and for socialization, etc., there's also some orthopedic aspects and interventions that can help them with that. And so, like I said, the disease-modifying agents are really changing attitudes, but still focusing on the function of the patient and making sure that we don't do too much. Let's talk a little bit about scoliosis. This is the most common reason for an orthopedist to be involved with patients with SMA. It's very common. About 60 to 90% of people in type 2 and type 1 will develop scoliosis. But its onset is earlier than people who don't have a neuromuscular condition. And in SMA, it can come on as early as 8 years old and even before that. This proportional to functional level as to whether you get scoliosis and how much it progresses. And disease-modifying agents are likely having an impact, although we don't have the data to really tell you for sure at this point. Scoliosis is treated to prevent seating problems, issues relating to caregiving. And there is a concurrent decline in respiratory dysfunction, which is quite variable. And there may be some impact of scoliosis, but like I mentioned, probably not as much as we had given it credit for in the past. For some patients, bracing can be useful. But unlike in idiopathic scoliosis, for example, we use these braces for seating support. You have to be careful because it can exacerbate the respiratory dysfunction in these patients. As you can see in this child here with type 1 SMA, you know, having a clamshell orthosis around you could interrupt your breathing pattern. And you can see the hole here for his G-tube cut out, and also to allow his abdomen to kind of poke out to help with his respiration. A semi-rigid rather than a very hard plastic one is best if you're going to use it, but it does not improve the scoliosis. It's really just for seating support. After the curves, the scoliosis curves on X-ray, the angles of those curves get to above 50 or 60 degrees. That's when we start to think and talk about surgery. Here's an example on the right-hand side. You can see a child who has a severe scoliosis, and that curve I'm mentioning is we measure an angle from the major curve of the whole scoliosis deformity. And we can straighten that up with some screws and rods, as you can see here on the right side, and do a pretty good job of getting a level pelvis for seating and a balanced spine above that. And that's really our goals, as well as to get a solid fusion. The goals are comfortable seating, ease of caregiving, social interaction, being upright and at the same level as your peers, decreasing pain, and of course, we want to make sure that the benefits outweigh the risks of this type of procedure, because it is a big one. As far as the role of disease-modifying agents in scoliosis surgery, I don't really think it's preventing the onset of scoliosis, but it's certainly helping improve function and decreasing the medical issues related with these big procedures. Patients seem to tolerate it much better if they've been using these agents. There's two real main types of scoliosis surgery. One is growth friendly, so that's used for younger children, younger than 8 years old, with a large curve more than 50 or 60 degrees. And we're using these rods which can elongate over time, growth-friendly type surgery, which can grow with the patient, although it takes a little intervention to do that. Or just like the one I showed you before, this is a solid fusion all the way through, where it's really a one and done, and we want all those bones fused together so we don't have to do anything else with this one again. But this is after children reach their true thoracic or chest height, where we're not too worried about making that chest cavity too short. I alluded to this before about the what the role of scoliosis or spinal curvature is in respiratory dysfunction in SMA, and it's always been a bit of a conundrum for me, as I noted that despite scoliosis surgery, that the pulmonary function, depending on the type and what their treatment's been, has continued to get worse over time, although quite variable. You can see this a chest X-ray on the right-hand side here, showing this bell-shaped chest in this child who has SMA type 1, and this tends to progress despite having the curve instrumented. The ribs tend to sag. There's a lack of support to pull the diaphragm down and to expand the lungs. Respiratory decline tends to happen over time, probably more concordant with the muscle weakness around the chest rather than anything we do with the spine. Prior studies that showed that an impact of scoliosis surgery really were poorly designed, and there's very few studies that have a control group where you can see the true impact of scoliosis surgery on respiratory function. So is this a chicken egg, or is it two different chickens? I kind of think it's two different chickens. Here's a young man from a partner of one of my previous partners who has type 2 SMA and a curve there. He had this growth-friendly surgery. And if you look at his chest cavity, you can see it's looking quite wide and robust. And this is a growing construct. But over a few years, despite that, and despite lengthening of the spinal column, the chest tends to still deform, and his respiratory function did go down along with that, although he's still doing quite well. We decided to look at this and look at all the literature that was there about that had pulmonary function tests before and after surgery, and a long enough follow-up to be able to tell if surgery had any impact on pulmonary function. And we really found that out of all this, when we pulled all those studies together, that surgery was associated most often with decreases in pulmonary function. At the best, it had a decreased rate of decline over time, but does not reliably improve pulmonary function over the preoperative baseline. So we need to make sure that we're doing surgery, and when we're talking to patients, and when you're considering these type of things, that you know why you're doing it, and don't want to give you the wrong impression as to what it can do for you. There's definite benefits to this surgery, but for different reasons than pulmonary function. That said, the literature we have is still, unfortunately, not that great, and we really need to get together in multi-center studies to answer this question in a better way. Hip instability in spinal muscular atrophy is really common, and it's common across the neuromuscular spectrum, with cerebral palsy having lots of studies about this. But because of the lack of attention on SMA hip instability in the past, there isn't a lot of studies out there. We've started to do a few in our own institution trying to answer some of these questions. But the hips coming out of the joint are related to hip abductor weakness, so weakness around the hip, and kids and young adults who don't weight bear are at a higher risk of that or can't walk. And I'll show you just exactly what happens here. But the reason why we're interested in hip instability is because without treatment, these hips will tend to go on to dislocation and osteoarthritis. So just like you might get when you're an older person, you certainly don't want to get it then, but you don't want to get it when you're 13 or 14 years old, I would assure you that. And kids with SMA have normal pain receptors. They're going to feel osteoarthritis just like anyone, but because of their low tone, not everybody gets pain from this, and that has really clouded our approach to this over the years. Here's a child with type 1 SMA, and you can see how here's the hip the ball in the socket on both sides at 2 years old. And as he grows, you can see that the hips are now basically subluxing, we call that, out of the socket until it eventually goes on to dislocation. And that happens over time. What's happening here? Well, we now know that the growth plate is really at play with abnormal muscle tone causing the growth plate to tilt to the outside or tilt laterally. That causes some pressure on the cup, which should be a little rounder like this one, although this one's not too great either because this hip is halfway out of the joint. But you can see that the cup is not really a cup at all. It looks more like a plate from the ball pushing on it in growing bone, and that causes progressive lack of support, and the hip will eventually dislocate. Here's a patient who has type 2 SMA. They also go on to have hip instability. And you can see at 2.5 years, her hips were in the joint nicely. They look almost normal, I would say. And around age 5, about 40% of it is out of the joint on this side. And then by 7 years old, it's really progressing out of the joint. The ball is starting to become more flattened. And just like you saw in that last picture, the socket is also becoming more like a plate than a cup. And our indications of surgery will, in these cases, are if the child develops pain, or for people who are walkers, because we know they have a higher risk of painful arthritis. And we're also considering the disease-modifying agents and the treatment as a possible indication. That's what we're kind of up against right now, trying to determine, who really needs this type of surgery and who's going to go on to have problems. So with higher strength and higher ambulatory capacity, then hip instability seems to still be around, but it may cause more of a problem than it did in the past. If you treat it, what do you do? Here's some intraoperative x-rays. So I'm teaching you how to do it now. Don't try this at home, but you want to direct the ball into the socket. We use a special type of plate to hold on to the soft bone in SMA. And so first we put this little, we call it a seating chisel, and then we cut the bone here. You can see we take out like a triangle of the bone, and then we take the triangle out and tilt the ball down towards the socket. You can see here now it's more in the socket. Socket is still flat. We need to deal with that one. But this gets and we put some screws in there to hold the plate there and hold the bone ends together as they heal over about 6 to 8 weeks. And that's an older style of plate that was used, but a real workhorse that many people still use today. We reshape the hip socket by kind of using a certain type device to just kind of cut around the hip socket and then mobilize it. And we could just distracting it there. We put a piece of bone in there so that after we do both of those procedures, you can see we've got a relatively round socket and the ball is in it now. So better force distribution and less risk of developing that arthritis or having it progress. And here's that girl I showed you earlier with her hip almost out of the joint, and then after that same procedure that I just walked you through. So goal, prevent arthritis, and in people who are sitters or are unable to walk, to improve their seating, but also improve positioning. And for children who have, or anybody who has their legs starting to cross together, for those people, we do loosen up the groin muscles as well, which helps with perineal care, so cleaning around the private areas and things. Those are important. Like I said, at Nemours duPont, we really were interested in hip instability, not only in SMA, but also in other neuromuscular disorders. But we have enough patients to really look at this carefully. We wanted to see what are the risk factors for the hip coming out of the socket. Out of all of our population of children with SMA up to age 21, we looked at all those patients, looked at their x-rays and determined when the hip was coming out of the joint, the timing of that, and what are the risk factors associated with it. We thought things like the genetic severity, so the number of SMN2 copies might be important, the type of SMA, whether they've had Spinraza or Zolgensma or any of the other disease-modifying treatments. Most of our patients were nusinersen or Spinraza. And their walking status. We also looked at the Hammersmith Functional Motor Scale, which is one of the scales we use a lot in looking to determine the response of these disease-modifying agents and the presence of scoliosis. When we looked at everything, we saw that the hip instability was extremely common, 74%. If you compare that to cerebral palsy of 35%, this is more than twice the incidence there. The age of onset was also quite young at 4.5 years old. So we need to be looking for this quite early. Out of all the risk factors we looked at, the independent risk factors, meaning those ones that alone could be responsible for the risk of hip instability, was the type of SMA, with type 1 and type 2 being more at risk than type 3, which kind of makes sense, and also the SMN2 copy number. The risk factors that did have some significance at the initial analysis, but didn't really come out in the wash, were the disease-modifying agents, the walking status, and scoliosis. So these are all likely because they're related to these more major factors. So even though DMA treatment doesn't seem to prevent hip instability independently, it likely is making the patients more functional it could potentially make these hips cause more of a problem in the future. We found that the Hammersmith score did have some use in that those kids with a score over 35 had a less risk of hip instability. So should we treat hip instability in SMA? I mean, I think that's a very good question. I think some people would say absolutely not, never, based on previous data and older literature, which had high complication rates. The medical management wasn't as good, and they really didn't look at outcome measures which matter to patients. They mostly looked just at x-rays. With the advent of disease-modifying agents, improve function, improve health in kids with SMA, patients being stronger, more ambulatory, and can tolerate bigger surgeries, we're really looking at this again because some kids do get into pretty significant problems with hip instability and arthritis, as I'll show you. Oops, excuse me. Here's a 16-year-old with type 2 SMA patient of mine who had progressive instability, didn't really want anything done for it, but developed a painful left hip there with severe arthritis and came back really saying, is there something we can do about this? And so we did the surgery that I had already showed you how to do, and her pain was markedly improved after that. And she was happy that she got it, and she did well. So what we're wondering is, will we see more of this after these gene therapies where kids are stronger and the forces on their joints are much more significant? Let's move into muscle contractures in spinal muscular atrophy. They're very, very common, pretty well ubiquitous, meaning all patients with spinal muscular atrophy are going to get some tightness in the muscles, and that's what I mean by contractures. The imbalance of muscles around the joints lead to these persistent deformities, which over time the muscles become more fibrotic and there's less contractile tissue there. The lower in SMA, the lower extremities, so the legs, are more involved than the arms and forearms, shoulder areas. And most typical presentations we see are tight heel cords with toe walking or a toe walking type position. Knee flexion contractures, meaning you're unable to completely extend the knees, and also hip flexor contractures. So you can't, you're kind of more like in a seating type position. It's very difficult to bring your hips out of that position. In addition to those muscles that cause the legs to cross, the hip adductors, and those that make, less commonly, the ones that make the hips kind of spread out, and that's called the abductors. They can all get tight and contracted and stiff, and sometimes they need intervention to help with positioning and standing and walking. Foot deformities are also extremely common. Some people, particularly with SMA type 2, will develop a plano valgus deformity, meaning a flat foot. So when it's very flat, I'll show you an example of that. And others will develop this type of deformity, which we see more commonly in the type 1 patients, with equinovarus foot, which you say, well, if you're not going to be walking, what does it matter? Well, it does matter. In a lot of cases, you can develop discomfort, and also, having to put your foot on your wheelchair foot plate if it's turned over on itself. Some people can actually get quite a bit of discomfort from that, and even pressure areas. We don't treat them unless there is a problem, but they can require that. Contractures worsen by the SMA type, so the lower the type, the more likely you're going to get contractures and the more severe they are. And also, the longer you follow patients out, the more likely they are to develop contractures. We use a lot of braces in the muscle clinic, particularly in SMA and Duchenne muscular dystrophy and the like. And they may delay the onset of contractures, but they don't prevent them. So although we advocate for things like night splinting and this in certain cases, we need to be honest with ourselves that despite all that, you're still likely to develop contractures. The foot is an important thing for standing, for walking, for positioning, as I talked about. But if you are one of those patients who can stand or take some steps, then it is a good lever arm to keep you upright and to help decrease the amount of muscle power you need to use to do that. This is, if you remember any of your physics from high school, you'll know that this is a lever arm, and there's a force of the ground on your foot, which acts on that lever arm. And if the force is in front of the knee, then it'll push your knee back into a stable position where the muscles don't have to turn on. But if this force is behind the knee, then your knee will bend, and you'll need to keep those muscles on to keep you upright. So this is someone who has one of those flat feet I was telling you about, where it really bends in the wrong place, and that force is a lot closer to the ankle, so that lever arm is quite a bit smaller. So this foot isn't as good at keeping you upright. But if you use a brace in a foot that's otherwise flexible, you can turn that type of foot into a stable lever. If the foot is quite stiff, then sometimes we need to do surgical interventions to get it to be able to be in a brace so that you can take advantage of the braces. The goals of muscle contracture surgery in SMA there are many aspects to it relating to function. To improve sitting, if you're a wheelchair sitter, making sure your hips are in a good position and your knees are not too contracted and your hips are not too wide or too tight. Those things are all important. To improve standing, traditionally we're looking at more with kids with type 2, but with the disease modifying agents, a lot of our kids with type 1 now are doing that to help with their bone health and socialization and the like. Improvements of walking have traditionally been for type 3, but now we're seeing that with type 2 as well. So it's really changing how we look at this patient population. Improving the, as we talked about for shoe fitting, improving positions of the feet and ankle is important for that. Here's a picture of a patient who I'll show you a little bit later who had a knee flexion contracture, which impacted her walking. Equinas, you'll hear me talk about aquinas. Equine is horse. I guess it's like the horse's hoof that's pointing down to where it came from. But basically, this means your gastrocnemius, your soleus, your calf muscle, which attaches into your heel cord or your Achilles tendon, causes you to be up on your toe. And if you're walking or standing, having that happen to a certain extent can be helpful in that it keeps that ground reaction force, the force of the floor on your foot in front of the knee, which allows you some stable support at the knee. But if it's quite weak or someone lengthens it way too much, that can make it a lot difficult for that force to do the job it needs to do. This is an area where we do some surgery on that. I hope no one's squeamish in the audience, but this is the gastroc muscle here, which we are releasing to help with some toe walking. But we don't want to overdo things. This is a very low dose area to do that type of surgery, and very high dose area down here. So we stay away from that area when we're treating kids with SMA. We want a little bit of toe walking to help support their biomechanics. Here's someone who, as one of my CP patients who came from another institution who had previous heel cord lengthening, and unfortunately that ground reaction force went behind the knee, as you can see there now, and he's in this crouching type pattern, which means that the quadriceps muscle in the front, the quads, needs to always be on to keep them upright. If that wasn't on, they fall down. That's a very energy expensive muscle, and we know it's weak in SMA in many kids. So you need to be really careful about doing surgical interventions on the muscles. Here's one of my friends who is 10. She has type 2 SMA. She was in an early, she was one of the early participants in the nusinersen trial, and has done very well with that therapy. You can see that without her braces, she is having a little more trouble. She's got some flat feet there, which don't support her as well as her brace does, and so a little bit slower in her ambulation. When we look, we'll show you another picture of her in her braces in a minute. If you look at the way she's changed, this is from our Gait lab at Nemours. So we look at our patients with videos, and we do lots of special markers, which give us graphs and things to show us exactly what's happening at every level. And in addition to that, we look at their strength and their range of motion of their joints. And if you look at when they're 5 years old in the green to when they were 10 years old in the red, at the hip, you had 15 degrees of hip extension when she was 5, and now it's minus 15. That means she's contracted up by 15 degrees. So that's a 30-degree change in her tightness of her muscle. And I know that she's done everything she can to keep herself stretched out. So it's not for lack of trying. This is part of the progression in muscle contractures we see in SMA. Knee flexion contractures, which is basically one of our major issues right now, also have gotten worse from being quite low when she was 5 years old to now 25 degrees and 23 degrees, so quite contracted. Now, her strength did get a little bit worse over the course of that 5-year span, but she did improve in her strength in her lower, in the lower part of her legs. And so that's a good thing. And her quadriceps function didn't change. Likely has some input from the disease modifying agent she's been on. Here she is in her braces now. And her cane's a little more functional. Sorry, a little more faster. You can see she's quite stable, very determined. But those the knee flexion there keeps that ground reaction force going behind the knee. And as such, she has some trouble over time with fatigue. And so what can we do to help with that? Well, we don't want to do anything that can cause patients to be off their feet for any time or put them in casts for a long time or anything like that. So there's been some recent developments in this area using the growth plate, the power of growth in growing children, to help cause deformity corrections or correct these contractures over time. And at the knee for flexion contractures, like you can see here, we put these screws in the front across the growth plate here. So we tether the front part of the growth plate. We leave the posterior, like the posterior 2/3 from the back, free to grow. And that kind of tethering causes the knee to grow into extension over time. And we don't need to cut the bone or do big osteotomies. We don't have to take the kids off their feet. We don't have to use casts. So this gets them back on their feet as quickly as possible. And so we can not have any delays in getting the rehab going. You do have to wait for it to happen. It only happens about 1 degree per month correction. So it takes time for a significant deformity. This one could take up to 2 years for it to grow. And of course, you need to have growth remaining for it to work. Here's one of my other patients when we're using a different kind of implant, but same idea. I just wanted to show you the sort of the principle of that, the slow growth into extension over time. And we call this guided growth. If you are going to do surgeries for SMA, orthopedic or otherwise, you need to be really have kids optimized and young adults optimized for this. Sorry, I'm a pediatric guy, so I can't help but say kids all the time. Respiratory optimization is one of the most important, and pulmonary function tests are essential. You know, it's variable how pulmonary function changes over time. Maybe someone else is giving a talk on that today, so I won't go too much into it. But it's really important to have your pulmonologist look at that. And I'm lucky to work with great pulmonologists in our muscle clinic. And we really do things in a multidisciplinary fashion. And I think that's the key to success in these surgery. Nutritional optimization is very important. A lot of our kids now are getting G-tubes, which is helpful to optimize the nutrition, but you don't need it. You don't need a G-tube alone to do that. But we have our nutritional support team, which is part of that to help decrease infection risk by optimizing nutrition and also improve the wound healing. Bone health is very important, particularly if you're looking at doing like surgeries on the long bones in the lower extremities. Remember that plate I showed you that we use? Well, if the bone is very soft, then it's hard for it to hold an implant. You have a higher risk of fracture and things like that. So we do bone density tests before any kind of surgical intervention like that. We do it well in advance so that if there is a need for some bone hardening drugs, like we call bisphosphonates, then we can get those in place well in advance so that the time of surgery that, you know, we can be happy that the bones are of sufficient quality that we can decrease our risks associated with bone fragility issues. Just a little bit about about braces. It's not a brace talk, and I didn't talk too much about them. But in general, you know, we're dealing with muscle weakness in SMA, and it's muscle weakness around the hips and in the quadriceps, and it's related to the SMA type, of course. But for the most part, I would think a solid ankle foot orthosis that will give you the best support. It'll keep that ground reaction force we talked about at the tip of the toes, in front of the knee, and will allow to correct the flexible foot deformity. It does require you to have at least ankle motion to about the neutral point for it to be effective. And of course, without a hinge, if you are someone who can climb stairs, then maybe this is not the best brace for you because it will impact that. So, you know, in general, you know, different patients need different braces. So you need to see what the patient needs and pick the right one. But remember, as we talked about, bracing is not likely going to stop the development of muscle contractures, but it might slow them down. But for standing and doing some walking, braces can really help, as you saw in our last patient I showed you. So in summary, I hope I'm not taking too much time here, but in summary, disease-modifying agents that target SMN1 and 2 genes have been shown to improve function in SMA, and they've really changed the way that I think about my patient population now over the last 18 years I've been doing this. And it's made us more optimistic that we can help and do things that are safer and with better outcomes than we could before the advent of these agents. Despite treatment with disease-modifying agents, orthopedic problems seem to continue to develop. We've seen that with other disorders who've had gene replacements as well in the skeletal dysplasia world. But function's better, and medical aspects are better. And we're hoping that that leads to better outcomes when we look at it in longer outcome studies. Given the improvements in strength in DMA with disease-modifying agents, most of us who do this type of thing are really looking more carefully at the hip and worried about the development of hip arthritis if we leave it untreated in these kids who are stronger and have higher joint forces. That's the way it goes in other neuromuscular disorders that have higher tone, and that is something that we're concerned about. So we need some more studies to really look at that in detail to really tease out what the best approach is there. So that's a work in progress. Scoliosis surgery has been around for a long time, but I think we know now that it is very useful for the functional goals and issues relating to quality of life, but probably not as useful for pulmonary function improvement. So that should be a very, very secondary goal when you're looking at scoliosis surgery. And if you are going to do surgery, you you should be someone who has some experience with this patient population, and you really need to focus on functional goals. Don't do too much. Do what you need to achieve the functional goal, and also pay very close attention to the surgical dose. You can really overdo it, and like if you take too much of any kind of drug, you can cause some problems. So you need to be very thoughtful when you do surgery on muscles in spinal muscular atrophy. Just a plea to anybody who's out there who's doing this type of thing, you know, our medical literature has lagged behind the advances in gene therapies in SMA, and we need more studies to determine the changes in orthopedic outcomes, both for surgery and for natural history in this new era. I really appreciate the invitation to be invited here to speak at the MDA, and be happy to take any questions.
Thank you so much, Dr. Howard, for your presentation and the wealth of information on orthopedic aspects and considerations. We do have a couple of minutes for Q&A before we transition into our next segment. So if you have any questions, please chat them in to our Q&A bubble here. It looks like we have one. Are hip fractures more prevalent in SMA2 individuals? I'm 60 years old and have very low bone density, so this is a concern to me, especially knowing that the hip can come out of its socket.
Yeah, thank you for that question. You know, the development of where hips become unstable and come out of the socket typically happens during the growing time. So if you can have some progression after you stop growing, and there really is very little in the medical literature to tell us how things, what happens in, you know, at your age. And I'm hoping that we'll be able to get that data over the years. Fractures and bone fragility is a problem in all patients, you know, with neuromuscular disorders, but particularly those who don't put a lot of weight through their bones. And so paying attention to bone health is really important. Working with your PCP to make sure your vitamin D levels are high. We use things like standers and gait trainers in the younger population to help load the bones to get the better density and help them be stronger. But even despite that, you know, it can be difficult. So I think there is an increased risk of fractures in general, and bone density is lower in SMA type 2. But there are things you can do to help mitigate that, and I think really paying attention to your diet and working with your PCP can be one part of that. I don't know if that helps too much.
Yeah, thank you for addressing that question, Dr. Howard. It looks like that was the only question in so far, so we'll just wait one more minute before we move on. Okay, another one came in. I have a type 1 treated that is about to be 6 years old. We have been seeing ortho for a couple of years and monitoring scoliosis and hip dysplasia. We are thinking he would benefit from hip surgery at some point, but our doctor was hoping to see some data on this, recognizing it is lacking. Is there an optimum age for this surgery in your opinion?
Yeah, thank you for that question. I mean, that's really the question we're grappling with now, as we see kids with type 1 SMA doing so much better. And I have, you know, a number of patients, including one coming up fairly soon, in the very same boat. And you know, her hips have gone on to have some discomfort and pain. And you know, we're making the decision to do hips at this point for people who are having functional problems with them. So discomfort, not just based on an X-ray at this point, or if you are, you know, a type 3 or a higher functioning type 2 who does walking, then those are indications I think we can all agree on, that if you have pain or you're a walker, then we should definitely get that surgery. But if you're not having pain and you're not and you're not doing any standing or walking, it's hard to make that decision, because there are, you know, the data in the past would say that probably only about 20 to 25% of kids will get into painful arthritis despite a hip dislocating or whatnot. That's probably underestimated. In the cerebral palsy literature, is 90% of those kids, but they have a higher tone, higher muscle tone. And I'm sure that has something to do with it. We know it has something to do with it. So that's why as we see kids get stronger and the muscle forces get higher, we wonder if that pain profile is going to get worse over time. I don't have a great answer for you on your child. I think at this point, we still have to individualize our treatments. If I see a hip going on to dislocation, it makes me nervous to let it go there, you know? So we do have a discussion about that. We look at the health of the patient and what we feel that they can tolerate. But certainly you need to really look at all the aspects of it before you make a decision in that circumstance. I'm hoping to have some more data for you. We're just looking now, we've just really, in fact, the data I gave you today on the prevalence of hip instability hasn't been shared before. So please don't share with anybody. We're just going to present that soon at the American Academy meeting. But you know, we're hoping to look at more functional outcomes coming up, as we do have a cohort of patients now who have been on nusinersen for quite a while. So I'm hoping we'll have more information, but it's still probably a few years away.
Great, thank you so much. Unfortunately, I do think we need to move on with our next presentations, but I thank you again, Dr. Howard, so much. It was a pleasure having you today, and we hope to have you back for future presentations.
It was my absolute pleasure, and thank you for the questions. Take care, everyone.
Thank you very much.